Diabetic emergencies and altered mental status. Now, for some reason, the whole diabetes thing is very confusing to students. So I'll explain it once, and I'll explain it all semester if we need to. If you have any particular issue with it and you can't figure it out, come talk to me. I'll find a way to explain it to you. Once you get it, if you can understand the process, then signs and symptoms and all that stuff will fall into place. So it's important that you understand how we get to that point so you can recognize signs and symptoms. And we're going to look at altered mental status too. So this chapter will also have stroke in it, seizure, things you've heard of, but we're going to be looking specifically at signs and symptoms and then how to treat it. Pathophysiology, mental status regulation. Now, this is something that they've added to your curriculum in the last couple of years, but in the olden days we didn't have to know it. But I know that it's on registry, so we are going over it. The reticular activating system. That is going to be the system in your brain that allows you to remain conscious. So if you think of that, it is what allows you to remain conscious. It's part of that neurological circuit in the brain. Reticular activating system, RAS. It's responsible for functions of staying awake, paying attention, and sleeping. So that means that there's a significant number of you in here that have some issues with your reticular activating system. I'm not going to ask you to raise your hand because you probably are at a low level here and these are issues for you. Keeps you alert and oriented. So when we start looking at people with seizure activity, people who have had a stroke, people who have had a head injury, the reticular activating system is a big player in that whole game. Oh, I had a thing there. Wake up. Which is not required by the brain. Let's see what y'all read. Okay. So some of us didn't read. And whoever picked this one, I'm worried about. Potassium. I told you that on register you will not have any negative questions. I hate negative questions and I try to stay away from them as much as possible, but I couldn't figure out any way to ask this. Requirements to maintain mental status. There are 3 things that the brain absolutely requires. It must have oxygen to perfuse the brain tissue. All of our cells have to have oxygen, right? Glucose. We have to have glucose in the cells, all the cells, in order for them to operate correctly. Glucose is particularly important to brain cells. They're very sensitive to low glucose states. And water. The tissues must be hydrated. If we are very dehydrated, the brain is not going to work well. We have to have water. So these are the 3 things that are absolutely required to maintain mental status. A deficit of any of these, and you're going to see an altered mental status. Causes of altered mental status. It's deficiencies in oxygen, glucose, and water will cause altered mental status. Trauma, infection, chemical toxins, all kinds of things can be detrimental to brain tissue, can cause altered mental status. Or you can have a primary brain problem, and a stroke would be an example of that. You know, if you've got a blood clot in the brain or you've had an aneurysm in the brain, that's going to interfere with your mental status for the same reasons that trauma to the brain, head injury, would cause that. Or it could be a problem with something else like hypoxia. Hypoxia usually is not a problem within the brain, but secondary to some other problem. So if you've got a patient with asthma or a patient with COPD or a patient with a pulmonary embolism, then you may have hypoxia to the brain. So it's not going to be a primary problem, but rather a secondary problem. Does that make sense? Okay, when you're assessing a patient with an altered mental status, and that's what we're talking about, you have to be very concerned and be alert for your own personal safety. A patient with an altered mental status is not operating on all cylinders. So they could be a danger to you and you not be aware of it. Sometimes, even in the presence of a person with a head injury, if they are very combative, you may need law enforcement. just to help restrain them so you can help them. So scene safety, your personal safety is going to be very important. Hypoxia is one of the most common causes of altered mental status. If you've got a patient with an altered mental status, I'm going to be looking for hypoxia. In fact, think of the three things that you have to have, right? Oxygen, glucose, and water. Oxygen and glucose are going to be your top two altered mental status causatives. You want to, when you're doing your primary assessment, you want to see if you can identify anything that's life-threatening. Hypoglycemia, low sugar to the brain, is life-threatening. That can kill your patient in a very short amount of time. If there's no sugar to the brain cells, the brain can't operate. And it's the brain that tells you to breathe. It tells your heart to beat. So without that, it can be life-threatening in a very short amount of time. Anybody with altered mental status, they're probably going to get some oxygen because there's a good chance it's going to be due to hypoxia. As part of your secondary assessment, after you've done your ABCs and you've ruled out or managed any life-threatening problems, now you've got to look at your secondary assessment to see if you can figure out why they're acting bizarre, why they have an altered mental status. So beyond ABCs, your secondary assessment may reveal the problem. You know, it could be, you know, they've got a spider bite or, you know, something that could cause that. Even a very slightly altered mental status can be a serious critical problem because it's probably not just going to stay like that. It's probably going to be a deteriorating state. Secondary assessment, you got to do your complete assessment. You got to do a good history of current illness, pertinent past medical history, and then you're going to have to do a body systems exam. With altered mental status, and you don't know the cause, you're going to have to start going through the body systems. If it's hypoxia, why is it hypoxia? Is it that they're hypovolemic, they don't have enough circulating blood volume? Is it that they are having a heart attack, the heart's not working well? Is it just hypoxia, a low oxygen state? Do they have a head injury? Have they had a stroke? You know, are they diabetic? And those are different body systems, so you're going to have to play devil's advocate here, going through all the systems to see if you can pin down the cause. If the patient can't give you good information, you're going to have to talk to the family or bystanders. You may have to look around, look at the scene to see if you can get an idea of what could have caused the altered mental status. But most commonly, your family, hopefully, is going to be able to give you some decent history there. One of the main things you need to get is the patient's baseline mental status. Now, could...
That's what I was going to ask.
Do what?
What if they already have it?
Well, that's the whole history here. That's why you need to find out, are they always like this? If not, how are they different today than they were, you know, last week? So you need to find out what their baseline is. What's normal for them? You know, if they had a stroke years ago and they have a chronically altered mental status, you know, then you've got to start from that point. And if they've called you, they've called 911 and you're there, then there's been some kind of change. But you're not going to recognize the change unless you know what the baseline is. So make sure you get the baseline on that, particularly for your elderly patients. Sometimes people may think that their altered mental status is a chronic state. You know, they're 85. Of course they have an altered mental status. Not. Many of them have a normal mental status. And then for them to suddenly have an altered mental status, that's a change. So you need to know what their baseline is, but you've got to know to ask it. Don't just assume, you know, they're crazy. They're probably always crazy. You need to know what the baseline is. Look for any medical alert bracelets. What would be something that might be on a medical alert bracelet that would give you some tip about altered mental status?
Diabetes.
Right. If they're diabetic, hopefully it's going to be on there. If they've got a diabetic bracelet, that could very easily be the cause of their altered mental status. What kind of information about a patient's altered mental status that you might you obtain from the scene? Yeah, if you saw a whole bunch of medications, you might look at those. You know, if they take an overdose of some, you know, antipsychotic or, you know, some sedative or something. What else might you see on the scene? Do what? What'd you say? They might be on oxygen, so they might be hypoxic. What'd you say? They have a glucometer. It may tell you they've got a diabetic history. What about if you just see a bunch of, empty beer cans? They have an altered mental status. They've been drinking. Any illegal drugs, they may have around there. So you got to look around. Drug paraphernalia, medications. Don't forget evidence of trauma, particularly with your elderly. They lose a lot of their musculoskeletal flexibility as they get older, and they could fall, have a head injury, have a slow bleed, and they're going to have a slowly deteriorating mental status. So make sure you look for evidence of trauma. Okay, let's hit diabetes here. Glucose is, as we said, it's important to the functioning of the brain, right? It's important to the functioning of all the cells in our body. Glucose is a form of sugar. It's the body's basic form of sugar. Oh, I had a star there. I didn't even notice it because of my pretty chain molecule here. Hormone required to move glucose into the cell. Let's see, guys. Come on, one more. We have one more. Somebody's asleep, right? Okay. Hey! Whoa! Man, I haven't even said that word tonight. Shocker, shocker. Good job. Okay, things we need to know about glucose and about insulin. I think it's on this screen, yeah. Okay, glucose is a large molecule. Think of it as being too fat to get into the cell. It's just too fat. It just can't get in. It will not get into the cell just on its own, for the most part. It has to have insulin. Insulin is a helper protein, if you will. It's a hormone, helper hormone, protein. And it's going to assist that glucose molecule into the cell. So it's like they buddy up, and between them, they can get into the cell. Without insulin, glucose can't get into the cell, for the most part. So, what does this tell us now? We know we have to have glucose, we have to have insulin. Now, one thing specifically that you need to know about the brain doesn't require insulin to get glucose into the cells. And that's an important distinction. So remember that. Brain cells don't require insulin. All the other cells in the body require insulin. Brain cells are set up so that they can take that glucose, can absorb the glucose without insulin. That's an important distinction. Okay, insulin is produced where? What? That's good. I want to know too. Huh? What? The guts. Okay, produced by the pancreas. I think I was asking you guys that and I just gave you the answer. Insulin is produced in the pancreas. That's all you have to know about the pancreas right now. Well, I already told you that. Told you that. Okay, it's important that the glucose and the insulin are balanced. You need a nice balance there for everything to work. If you've got more glucose than you have insulin, if you don't have enough insulin, what's going to be the problem? It won't get into the cells. But if we have a lot of glucose and not enough insulin, where's that glucose go? Well, as much as it needs, so that's good. It's just going to go round and round. As it goes through the circulatory system, we've just got high circulating blood sugar. What do we call that? Hyperglycemia. That means we've got a lot of circulating sugar, but if we don't have the insulin to get it in, it doesn't do us any good. It helps the brain, but everybody else doesn't get the good stuff. That means all the rest of the cells in your body are not getting the sugar they need. That means my muscle cells that help me breathe, not getting enough sugar. Those aren't going to work good. Nothing else in your body is going to work well because there's not enough insulin. Too much sugar, but it can't get in. So I can just circling in, trying to get in. It can't get in. Oops, I already told you that. Diabetes mellitus. Diabetes, the word means to pass through. Mellitus means sugar sweet. So diabetes mellitus, that is going to be the form of diabetes that we're going to be spending our time talking about. There's some other forms out there we're not going to go into specifically. But diabetes mellitus means is sugar passing through the body. With diabetes mellitus, if you got too much sugar, where's that sugar going to go?
Finally goes out your urine.
Yeah, pretty soon it's going to go out in your urine, but your body wants to get rid of that sugar. What did I tell you about sugar a few weeks ago? The N word? It's necrotic. Sugar is necrotic. It tears up your vascular system, so the body says, you got to go. You're killing me. So how's the body going to get rid of it? It's going to urinate. It's going to dehydrate you trying to get rid of all of that sugar. So that's one of the things you're going to recognize about a patient that has hyperglycemia. They urinate a lot. If you urinate a lot, what's going to be the reflex action there? Yeah, exactly right. If you urinate a lot, then you're going to drink a lot of fluids to replace that so you don't become dehydrated. All right, there are two types of diabetes mellitus. Type 1, I've got IDDM, which means insulin-dependent diabetes mellitus. With type 1 diabetes, the pancreas doesn't produce insulin. Either it's not enough or it doesn't produce it at all. So it's an insulin issue there. Type 1 diabetes. We used to call type 1 diabetes juvenile diabetes because we see it very commonly in children, or we might say, juvenile youth, child onset, pediatric onset, type 1. Type 1 diabetics are insulin dependent. They're going to give themselves shots. Type 2 is non-insulin dependent diabetes mellitus. So these are your type 2 diabetics. This is usually adult onset, and the most common cause for that is the cells are unable to use that sugar. Unable to use the insulin properly. Needs the sugar. God, it's crazy. It's past my bedtime. So with non-insulin dependent diabetes, it's an insulin issue in that the cells become resistant to the insulin. So type 1, it doesn't produce enough insulin. Type 2, oftentimes there's enough insulin, but the cells are resistant to the insulin. Okay. Type 1 diabetes, the pancreatic cells don't function properly. Insulin is not secreted, not enough insulin to transfer the glucose into the cells. They may then take synthetic insulin or to provide that insulin. What happens to the body when sugar builds up in the bloodstream? What did I tell you? Yeah, it's necrotic. It just circles. It doesn't get in the cells. What feeds the cells? Glucose. Yeah, we've got to have glucose in there. Oops, I forgot I had that. I didn't have a star up. I just told y'all that. Juvenile diabetes is which one? If y'all miss this, we're in trouble. Woo! Thank goodness. Type 2 diabetics, the body cells can't utilize the insulin. The pancreas usually secrete enough insulin, but the cells can't use it. It just becomes resistant. Most of your type 2 diabetics are going to be controlled through medication and through diet. Whereas type 1 is controlled through what? Insulin injections, that's right. Okay, diabetic emergencies. We have two. Hypoglycemia, what does that mean? Low circulating blood sugar. Hyperglycemia is high circulating blood sugar. Okay? Hypoglycemia, there's not enough sugar in the vascular system. Hyperglycemia, there's too much sugar. We need a balance. Hypoglycemia, when you think about why there's not enough sugar in the vascular system, what do you think the most common problem is? Well, there's actually two problems that occur here. What can cause you to be hypoglycemic? So that would be too little sugar
Too much.
or too much insulin. Remember I told you that insulin and glucose have to be balanced. If you've got way too much insulin, then every little bit of sugar is going to be gobbled up and taken in there. But you need to have circulating sugar in there to get all the way around. So you've got to have a certain level. Like what's normal blood sugar reading? It's about 60 to 100. If you have a whole bunch of insulin in the circulatory system, it's going to gobble up that glucose and take it in, and there's no sugar to take anywhere else. That means there's no sugar to take to the brain, right? Because it's all zipped off and attached to insulin, so that's not good. So, to become hypoglycemic, either they've taken too much insulin or they haven't taken in enough sugar. If you have a diabetic that does, say they take, and this is very common, they'll take their insulin injection in the morning before they eat breakfast, which is, they should take those together. But if they take their insulin and then something happens, the phone rings, an emergency, they run out the door, go pick Johnny up at school because they had a problem, and they never eat, they're probably not going to get there because their insulin has sucked up all the sugar and they don't have any sugar for it. If your diabetic burns up that sugar, you know, if they go out and jog 20 miles, you know, or they have some unusual exertion, they burn up their sugar, then they've got a mismatch. They've got too much insulin and not enough sugar. They overexert. Also, if they're sick. Generally, our sick patients, you know, that disrupts their whole cycle. If the diabetic patient eats and then they vomit, their sugar doesn't get into the vascular system. Signs and symptoms. You need to know these because you're going to get patient descriptions, and you've got to know this. Hypoglycemia is a very rapid onset. That's going to be a key when you look at the difference between hypoglycemia and hyperglycemia. Very rapid onset, acute. I mean, we can be talking about 5 or 10 minutes. We're not talking about days here. You can have somebody that's completely normal, and then within 5 or 10 minutes, they have altered mental status, and 10 or 20 minutes later, they can be completely unconscious, depending on how rapid it goes about. Altered mental status, it can vary how they present. You may have a patient that's just confused. They kind of go into a stupor. They get that, you know, glassy-eyed look. You know, they're just not tracking you. They also, the flip side of that, they may be very combative. I don't think your book really emphasizes the combativeness side of that. But you'll probably have just as many patients that are combative. I mean, pissy combative. I mean, I'm going to punch your lights out combative. Like they have a head injury. And they can have like superhuman strength. It's amazing that they can be that combative. And there'll be patients that you'll see on a regular basis. They may be what we call brittle diabetic, in that they can check their sugar several times a day, but it just is very difficult to regulate. Do you know people like that? I mean, it just jumps all around. And you may respond to them on a frequent basis. I mean, I've had a few patients, I don't know why they're big, but they're these huge patients, and they would just beat the snot out of you. And then, you know, after you get some sugar on board, it's like, oh, I'm so sorry, I didn't mean to. I know. You just have to be patient with them. But you'll notice that their altered mental status, they can be very combative, or they can be very subdued and just go into unconsciousness, but it's a very rapid onset. Other signs, they'll be sweaty. It almost, you know, looks like a sympathetic response. They'll be cool, pale, diaphoretic, tachycardic. The respiratory rate may increase, but altered mental status is what you're going to see more than anything else. Hypoglycemia patients very frequently will seize. If they're hypoglycemic, they don't have enough sugar, what's happening to the brain cells? They're starving. They've got to have the three things, right? Water, oxygen, and we're not getting any sugar, then you're going to get some serious neurological issues, and seizure is very common there. So probably if I get a call for somebody with a seizure, the first thing we're going to think about is hypoglycemia. The brain and the body do not tolerate low levels of sugar. So low levels of sugar in the brain, you get a rapidly decreasing mental status. Brain cells starve, altered mental status, unconscious. You can very easily have permanent brain damage. Hypoglycemia is not a joke. This kills patients. It's never good. Did I go too fast? Then, of course, seizures on here, too. Okay, hyperglycemia, too much circulating sugar. Now, when we talk about somebody that's hypoglycemic, you can have a patient that's hypoglycemic. I mean, I could look out here and probably hypoglycemia is probably part of your issue the other night, too. You could be do what?
I was thinking the other one.
Hyper? You hadn't eaten anything. You know, you can have people that have a sensitivity to hypoglycemia, but they're not diabetics. You know, if you just let your blood sugar drop, then you may start showing some of these signs, but that would happen because you haven't eaten for a while. So with hyperglycemia, you've got plenty of sugar, but there's no insulin to take it into the cells. So you've got a decrease in insulin. Now, for you to have a decrease in insulin, we're talking about known diabetics here. These are diabetics. If you just occasionally get low blood sugar, that doesn't make you a diabetic. These patients would have very high blood sugar except the insulin or the medication that they're taking. So they may have a low circulating insulin. They forgot to take their insulin, or they forgot to take their medication, or they took their normal amount of medication, but then they ate, 3 Paula Deen cakes or something, where they have really high circulating blood sugar and not enough insulin for that. Now, would that affect the brain cells? If you're hyperglycemic, would that affect brain cells? In what way?
Because sugar's like that.
Over the long term. So yeah, so hypoglycemia is acute. You will have an acute response. With hyperglycemia, you've always you got high circulating sugar, and it is necrotic, but that would be a chronic issue, not an acute issue. So in order for hyperglycemia to start showing signs and symptoms, it's going to be a chronic thing. It's going to be the course of hours to days that it starts to be an acute problem, meaning where someone will call 911. You may have patients, well, for instance, I had a patient one time that she had been in a car wreck, and so we're doing all our assessment, I heard this, I heard that, we're doing an assessment. And part of my assessment, I was asking her some questions, and I said, do you urinate frequently? She was a little bit overweight. She was young, she was like 20 or 21, she was a little bit overweight, and I asked her, I said, do you urinate frequently? And she goes, yeah. And I said, well, do you find you thirsty? Do you drink a lot? She goes, yeah, I do. Well, those two things told me she's probably hyperglycemic. She urinates a lot, and she's thirsty because sugar is necrotic, but also the body tries to get rid of that sugar. So sugar is a diuretic. So if you eat a lot of sugar, you've got high circulating sugar, you're going to pee a lot, and you're going to be dehydrated. So that's one of the tip-offs. If you get a patient that tells you they're drinking fluids all the time, you know what? You need to have your blood sugar checked. It's not always the case, but there's a good chance that they're hyperglycemic. And they drink a lot because they urinate a lot because they got high circulating blood sugar. So anyway, they can have it in a chronic setting where they haven't become very symptomatic. So this is where they usually recognize that a patient is diabetic. Somebody becomes alarmed because they drink all the time and they urinate all the time. So those symptoms ring a bell for somebody. They go in and get checked. They got a blood sugar of 250 or something. Infection can cause a patient to be hyperglycemic. So a patient that maybe was becoming septic, they may be hyperglycemic. Stress can lead to hyperglycemia. Things just don't work right in those settings. You take in too much sugar and your insulin remains the same. then you're going to be hyperglycemic. What do you think the signs and symptoms of hyperglycemia will be based on everything you know now?
Increased thirst,
Thirsty?
urination.
You pee a lot?
Hungry.
You are hungry because not all of your sugar comes from just Coca-Cola. Most of your sugar is going to come from the foods that you eat. So, why would you be hungry if you have plenty of sugar?
Become lightheaded.
Not processing it.
It's not processing it. I got plenty of circulating sugar, but it can't get into the cells. The cells are starving to death. So all this sugar on the outside, no sugar on the inside of the cell. So the cells are starving to death. So the brain is saying, dang, I don't have any glucose in the cells. I've got to get some glucose. Where do we get it from? We eat. So hunger is one of the signs that you'll see of hyperglycemia. The brain is saying, I'm not getting sugar into the cells. Got to get sugar in there. It's kind of like the respiratory thing. If I'm not getting enough oxygen circulating, what's going to happen? I'm going to start breathing faster, right? I'm going to become tachycardic. Same thing, I'm not getting sugar in the cells. Well, I got to increase my sugar intake, right? Okay, I mentioned that it's slow to develop because you can have high circulating sugar as long as you have enough insulin to take in enough to keep a good mental status and keep your cells working, it's okay. But what's all that high sugar doing? It's dehydrating you. It's necrotic, so we know it's bad for you. You're thirsty. You're hungry. And what's the other part of that? You're thirsty because you're dehydrated, right? So if you're chronically dehydrated, say you're like really, really dehydrated, what's the skin going to be like? Probably dry. It's going to be warm. You have trouble cooling yourself. You don't have enough fluid. Increased urination. The three polys. These are the three things you're going to be looking for. They're going to point to hyperglycemia. Polyuria. Poly means what? Lots, many. Yeah. Polyuria, you're peeing all the time. Polydipsia, that means you're drinking all the time. Polyphagia means you're eating all the time. Your three polys. You're often very nauseated too if you're real hyperglycemic, apart from eating all that crap. Okay, results of hyperglycemia, you know this, profound dehydration. Sugar is a diuretic. Not only does it pull fluid from the vascular system, it's also pulling sugar from the cells. So the cells tend to shrink up, and that's never a good thing, particularly in the brain, right? Excessive waste products are released into the system. This is because if the cells don't have the sugar that it needs, if it doesn't have sugar for normal, what do we call that, energy production in the cell? What is that? ATP. Yeah, if it can't create ATP through glucose and oxygen, because it doesn't have glucose, it's going to start burning down fats and proteins, and that's very inefficient. So it's almost like anaerobic metabolism, even though anaerobic means without oxygen. Here it's doing it without much glucose, and it also is inefficient. So it's going to burn other things, fats and proteins, and it releases a lot of other toxins. It's very inefficient. But it does get some sugar out of it. Not the final result, but one of the worst results you'll see as hyperglycemia moves down that pathway is going to be DKA, diabetic ketoacidosis. Ketoacidosis is a result of this burning of fats and proteins. It starts to develop and release ketones. Ketones have that kind of sugary, sweet, acidy smell. Like have you ever taken off nail polish? That's a ketone. That's what nail polish is made up of. So your body releases these ketones, and they may produce this kind of sweet smell. But diabetic ketoacidosis really is just a buildup of acids, ketonic acids in the bloodstream, and it's very nasty. Okay, so signs of diabetic ketoacidosis. Diabetic ketoacidosis is not just hyperglycemia. You can be hyperglycemic and not show signs and symptoms. By the time it gets really, really bad, where you get really dehydrated, it starts affecting the brain and the other tissues, you get diabetic ketoacidosis. You'll have a profoundly altered mental status. These patients are most commonly unconscious. And it really results because they're so dehydrated, the brain doesn't work. Does the brain, in diabetic ketoacidosis, does the brain have, which of the three things? It's got oxygen, it needs oxygen, glucose, and water, right? What's it missing? In hyperglycemia, it's got the glucose, doesn't have the water, right? Because remember, the glucose can go into the brain cells, it doesn't require insulin. So there's plenty of sugar, there's just not any water.
So this one's missing water?
Yep. Profoundly dehydrated. So once you get dehydrated, think about all the impact that's going to have on your body. Think about you out there and you've run a marathon and you haven't drunk any water along the way. One of the problems you're going to get is a severely unbalanced electrolytes, right? You screw up your electrolytes, what's one of the first signs you're going to see of that? Major sign, cardiac dysrhythmias, because your electrolytes are the main player in cardiac rhythms. So once you're dehydrated, it's going to present just like low circulating blood volume, because that's what it is. So you're going to have a weak rapid pulse. It's going to be like hypovolemic shock. That's exactly what it is. Now, as the patient falls into this stupor, this diabetic ketoacidosis, acidotic state, their respirations are going to change. I mentioned this earlier when we were talking about normal respirations, regular and irregular. Kussmaul respirations, specifically for our purposes, will be tied to DKA, diabetic ketoacidosis. Kussmaul respirations are very rapid and very deep, and they go like this. It's kind of creepy hearing a patient breathe like that. Why are they breathing like that? It's not oxygen that they need. They're not really moving fluid because they don't have much fluid. Okay, think about the things we get rid of through the respiratory tract. We get rid of a lot of
toxins.
Yep, we're releasing all those ketones. When a patient's breathing like this, it's because they have that buildup of those ketones, which is acidotic, trying to get rid of those. So you're going to see very deep, rapid respirations called DKA. We see that in a couple other things, but specifically for us, we're looking at DKA. Yeah, you're just trying to get oxygen. These guys are trying to get rid of something. You'll notice that their breath probably smells like ketones. It smells kind of like that acetone. It smells like fingernail polish remover. It's kind of a sweet, yucky smell. And some patients, now not all patients will smell fruity like this, because we're going to look at another circumstance where the patient is basically presents like this, but it's not, they don't have the fruity thing. It's not, they don't create the ketones. They will have warm, dry skin because they are so dehydrated. This patient who is unconscious in DKA, if you touch their skin, they're going to have a fever. It's going to be hot because they can't cool themselves. It's going to be like hyperthermia. Of course, at that point, they're fixing to die. I mentioned just a second ago, there's a circumstance, we call it a HHNS, hyperglycemic, hyperosmolar, non-ketotic syndrome. Just remember HHNS. In this event, the patient is going to be extremely dehydrated, but they don't create ketones. Some other little issues going on. Not going to go into it. You don't want to hear it. You see this with your type 2 diabetics, usually in the elderly patient. HHNS, their problem is they are severely dehydrated. They don't make ketones. problem is dehydration. So remember that. If you see a question about that, HHNS, no ketones, but they're severely dehydrated. That causes their symptoms. Assessment, always anybody with altered mental status, you need to be afraid. Okay, watch out for your for your personal safety. Your assessment, find out about history of present illness. You know, what's going on here, how it occurred, when, blah, blah, blah. This is for all of your diabetic patients, hyper or hypo. If it's hyperglycemia, what do you think the duration is going to be? Extended duration. If it's hypo, what's the duration? Acute. Yep. Secondary assessment, make sure you get your sample history. You want to check them. A lot of patients these days, particularly your brittle diabetics, they may have an insulin pump, and it constantly is checking their blood and administering insulin as needed. So insulin pumps can be great except when they malfunction. That's never good. If you've got somebody that's depending on an insulin pump that has stopped working, they're not getting any insulin, and without that insulin, they become hyperglycemic very quickly. Look for ID bracelets. Look in the refrigerator. Insulin has to be refrigerated. So if you have any question, if you come in there, a patient's unconscious, look in the refrigerator, see if there's any insulin in there. If there are any other medications they take. We've looked at the blood glucose meters. We'll be looking at those again in the lab. But for all your medical patients, just get in the habit of checking the blood glucose. There's nothing wrong with that. But just about hyperglycemia can present as just about anything. And I will tell you this quick story, something I've already told you. I worked with a medic down there that ran a chest pain patient, got there, she had had open heart surgery 2 weeks before, did I tell you this? They got her he treated her all the way down the line for a heart attack because she just recently had open heart surgery. She had chest pain from it. Got her to the ER. First thing the doctor did was check the blood sugar. She had a blood sugar of like 29. They gave her some glucose. She was fine. No more chest pain. So the point I'm making is her hypoglycemia caused chest pain. Hypoglycemia can present like a stroke. They can have one-sided weakness. You know, I can't move my arm, and it's sugar. So get in the habit of checking your blood sugar on all your medical patients. Check it on your trauma patients. I mean, it's very cheap. 60 to 80 in a symptomatic diabetic is hypoglycemic. So if they are a diabetic and their reading is 60 to 80, for them, that's going to be hypoglycemic. For you guys that aren't, you know, diabetics, it's probably okay. Other people less than 50, usually you're going to see significant decrease in mental status. If it's over about 140, we're going to call that hyperglycemic. Your diabetic patients very commonly will run a higher, that normally, I mean this would be normal for them. So if they've got a blood sugar reading of 80 and they're diabetic, that's low for them. It might be normal for you, but it's low for them. If it stays high, then they're going to have some serious problems from that. Those are the people that have chronically high blood sugar and they don't realize it. They just pee a lot and they drink a lot. Then they're going to start having symptoms of that necrosis over time. So your monitor may say high or low. If it's like above 500, they're all going to be set at different rates. So it may read low if it's below 25. It may read low if it's below 15. So each monitor is going to be a little bit different. But if it says high, then it's really high. And if it says low, it's really low. But sometimes that's all you'll get. If you've got a patient who is hypoglycemic, they have an altered mental status, but it's not critically altered mental status. You know, they're a little bit confused. If they can eat, the best thing you can do is get them to eat. If they can swallow, do you want them to eat a candy bar? A candy bar might be okay for 5 or 10 minutes, but after that, they're going to bottom out even worse than they were before. So you want them to eat something, you know, scrambled eggs, a peanut butter sandwich, some kind of protein that'll break down more slowly. So you may give them initially a candy bar, but you're going to follow it with a peanut butter and jelly sandwich or something. If they are unconscious, you know, or they have a severely altered mental status, we don't want them eating anything because we don't want them to aspirate. They need to eat a high protein meal. That will stabilize their blood sugar, stabilize their insulin production, and prevent that spiking. It will give them enough sugar to break down over a longer period of time. Okay, we give oral glucose for our hypoglycemic patients, provided they have the mental status to take it. Usually they got to have a history of diabetes. You could have a patient without a history of diabetes. You check their blood sugar and it's 45. Guess what? We're getting sugar. They need to show some signs of altered mental status from it, but they need to be awake enough to swallow. I told you how nasty this stuff is. If your patient's ever had it before, they're not going to want it again. So you're going to have to work with them on that. They'll squeeze that into the mouth. You may use a tongue depressor and put it on there and put it in the cheek, and as it dissolves, then they just swallow it down. That's really the best way if it can dissolve in there, because some of that is going to pass directly through the mucous membranes into the vascular system, which is good. After you give oral glucose, you're going to give it, 5 minutes or so, and then you're going to recheck the blood sugar. You're going to recheck the mental status. Are they getting better? Oh, where's that question? I didn't have a star up. Okay. Which one of these presents with Kussmaul respirations? Ooh, what did she say? I can't remember. Pretty good. Oh. So, we have sleepers in here. Almost half the class slept through that one, right? DKA, what's that stand for? Diabetic ketoacidosis. Kussmaul respirations, these are people that are unconscious from high blood sugar. They're trying to gas off all of that sugar, all that ketones. DKA. Other causes of altered mental status. What number are we on? Why does it say 0 on there?
I don't know, there's all of it does.
I hadn't figured that one out. Okay, seizure disorders. A lot of things can cause a seizure disorder. It could be a head injury. It could be hyperglycemia, hypoglycemia. It could be an infection. Can you think of an infection that can cause seizures? Sepsis can cause seizures. I'm thinking about kind of a head thing. Meningitis, absolutely. Encephalitis, those can cause seizures. Any disruption in the brain's electrical activity can cause a seizure. I said that was good for me. Seizure is a sign of an underlying defect, injury, or disease. Good work. Okay, there are stages or parts of a seizure. You guys ever seen anybody seize? Yeah, it's pretty weird, isn't it? Yeah? You ever seen a child seize? Do you have kids? He just fell out. Just done fell out, huh? Yeah. Most common cause of seizure activity is non-compliance with medication. So most of your patients that seize, they have a seizure disorder, they're on medications and they're non-compliant. Most common cause. However, most of those people are not calling 911 because it's a known seizure disorder, they're non-compliant, they're around caregivers that are familiar with their disease. So many times we don't get those calls. The ones we get are usually hypoglycemia. Okay, so tonic-clonic seizure, what all have I got about this? Okay, so there's several phases. First is the tonic phase. Tonic is going to be when the muscles stiffen. So we start out with, somebody going to seize over there?
I'm just looking at everyone and they're all like looking down.
No, I just thought somebody was.
Oh, are y'all all texting? Is that it?
No,
Or looking down?
my phone was good.
Okay, just checking. So with tonic, excuse me, The tonic phase, they're going to stiffen. And usually that stiffening may go from 30 seconds to a minute where they just go stiff all over. That's the tonic phase. The clonic phase is when they're actually jerking. The muscles are jerking back and forth. Typically, this just lasts for a couple of minutes, but it can last for several minutes. It can be continuous also, but most commonly we have a short tonic phase, then we have a longer clonic phase. That's why we call it tonic-clonic, because this is whole body involvement, a tonic-clonic seizure. We used to call those grand mal seizures. So they're whole body. These are the ones we're called for. There is hundreds of different types of seizure activity, but we don't get called for those. Like there's absent seizures where kids get it a lot. You know, where you're looking at a 6-year-old and they're kind of staring off and you kind of go, hello, then they go, what? Like this. Like some of you guys kind of do that. Well, I think we get absent seizures in here. Yeah. So with those, we don't get called for those because they clear up in a matter of seconds. We get called for tonic-clonic seizures. Now there's a third phase to this, and it's the postictal phase. In postictal, if you can imagine, after a tonic-clonic seizure, the body's burned off a lot of sugar. You know, you're doing this whole shaking thing. It burns a lot of sugar. It burns a lot of energy doing that. So then we go in this postictal phase, where the patient is basically unconscious or has a severely altered mental status for a period directly after the seizure. So they slowly will regain consciousness. So most of the time, when we respond to a seizure call, we'll get there and they're either postictal or they're completely out of the seizure. It's not that common that we arrive and they're still seizing. If we arrive after a 911 call and they're still seizing, we're going to call that status epilepticus, which means they have had this constant seizure without an intervening period of consciousness. So that means that they've seized and they may have gone postictal, but they seize again before they ever regain consciousness. Or they may start seizing and they don't stop. They may seize for 10 minutes, 15 minutes. It's very uncommon, but it does happen from time to time. Those are very serious. Status epilepticus. I probably have it in here. It's like epilepsy.
So it's just constant seizing, or it's that other?
Yeah, it's seizures that have no intervening, continuous seizures without an intervening period of consciousness. So continuous seizures. Status epilepticus. The status part of that means is continuous. Like we talk about asthmatics, that you may have an asthmatic that has status asthmaticus, which means they have a constant, unending asthma attack that hasn't been broken. Now some patients, before they have a seizure, they may report an aura, which is like this. Isn't that a neat little picture? Y'all, any of y'all familiar with an aura, where people, they feel it coming on? Like patients that have headache, what's the thing? Migraines. They may report, they feel like they're getting ready to have that migraine that's coming on. Well, some patients will have an aura, which is a sensation that they have just before they seize. Probably fewer than, maybe 30% of patients will report an aura. And the aura may come in several forms. It may be a smell that they get just before, or a feeling, or something that they hear, or maybe lights. But they'll get some little indication that they're about to seize. And it's usually just a few seconds, usually not more than 60 seconds of aura before they seize. Smell, sound, or just a feeling they know they're going to seize. And this is kind of interesting. If you ever talk to patients with a seizure history, it's interesting when they'll tell you what their aura is. I used to work at a swimming pool in the olden days, and I worked at a pool that was very deep. It was 16 feet. And I remember watching a guy one time, and he was swimming laps, and all of a sudden he swam to the side and just held on. And then While he's holding on, he starts his seizure thing at 16, the depth of 16 feet. But he had an aura. He knew he was about to seize, so he got himself to the side, which I appreciated that. I hate him seizing out in the middle of the deep. So auras can be real handy. Not all seizures are generalized tonic-clonic. They're not all major seizures. You can have a partial seizure. Tics, no, I'm not talking about the kind that bite you, but a tic where somebody kind of gets a little facial thing or maybe a hand movement. So you can have seizures that occur in different parts of the body, but we don't usually see those. With these, a patient usually remains alert. So if they remain alert, what system in the brain is working well? The RAS, the reticular activating system, that's right. Causes of seizure, hypoxia. Outside of the patients that are non-compliant, we don't count them. Outside of them, the most common causes of seizure we'll see are hypoxia. This could be from a head injury, or just basically not getting enough oxygen. Strokes cause seizures very commonly. Head injury cause seizures, toxic ingestions, hypoglycemia. A lot of your hypoglycemia patients will seize. Brain tumors, it's a tumor. Brain defects, infection, remember we talked about sepsis, meningitis, those cause seizures. What does idiopathic mean? Only idiots seize?
It just comes on.
Yeah, idiopathic means they don't know the reason. They'll call it idiopathic. A lot of your neuropathy patients, they have peripheral neuropathy. It's due to diabetics because of that high circulating blood sugar. It's destroyed their nervous system. But sometimes it's idiopathic, meaning they don't know the cause of it. Epilepsy, these will be your patients that are known epileptics and they're non-compliant with their medication. Scene safety. If you've got multiple patients seizing at the same location, that should tell you that it's not a seizure disorder, right? It's not a personal thing. It means they've eaten something or they've breathed something. They've got something in common that's causing all of them to seize, okay? Do what? What?
Weren't there group therapy sessions?
Didn't work. Yeah. In that event, you're looking for some reason. They've ingested something or inhaled something. So in that case, if they're all seizing, you need to worry about your own personal scene safety, right? Okay. All right. When you're trying to do your assessment on a patient, a seizure patient, you want to know what they were doing when the seizure started. You want to know what the patient did during the seizure. One thing you'll find, you get called for 911. Seizures is something that people learn. They can say they had a seizure and where everybody's going to get worried about it, but they maybe didn't have a seizure. So we see a lot of fake seizures. So you want to find out what exactly occurred while the patient was seizing. When they describe, he was doing this weird thing. Really? Well, that probably wasn't a real seizure. But anyway, you need to know what they did. You need to know the duration. How long did it last? If it lasted several minutes, then you worry about other things. Has the patient gotten very hypoxic? Do they have a head injury? What's going on there? But one thing about seizures, as you can imagine, it's hard to estimate the time because they're so dramatic. They're so scary that a patient seizes and you ask somebody, well, how long did it last? Oh, 5 minutes. Probably lasted 45 seconds. So that can be difficult unless somebody's seen the seizures before. What did the person do after the seizure? Were they postictal? If they've had a major tonic-clonic seizure, they are going to be postictal. Now, that doesn't mean they didn't have some other smaller type of seizure, but they probably didn't have a big tonic-clonic seizure if they're not postictal. And that doesn't mean that you have to see them postictal, but if the patient describes, well, they woke up and they were just really groggy, and then slowly, they came around, well, then they probably were postictal. Okay, if the patient's seizing, say you're in someone's presence when they start to seize, you want to get them in a position where they're safe. Put them on the ground, put them on the floor, where they can seize. You don't want them standing up, where they're going to seize. You certainly don't want them in the swimming pool as they're seizing. There are a few very unsafe places. In the kitchen around a bunch of knives. That's never good. If you can, loosen their clothing so it can assist them in breathing a little bit. If there are any objects around there that they could hurt themselves on, make sure you move them so that they're someplace safe. Don't put anything in their mouth, okay? Don't try to hold them down. It's not going to work for you. Just let them do their thing. After the seizure is broken, after they've stopped, now we're going to do our ABC assessment. We're going to protect their airway. You can imagine that seizing patients may easily bite their tongue. They don't swallow their tongue, right? We've talked about the whole swallowing the tongue thing. You can't swallow your tongue unless somebody cuts it off and sticks it down your throat. So you can't swallow your tongue, but it can drop back and block the airway. So if they're unconscious and they're back like this, you want to position them so the tongue's not a problem. Place them on their side. We call that what? The recovery position? For a reason. Yeah. If they're cyanotic, you may have to bag them. You know, you want to know if their respirations are what? Adequate. Are they breathing adequately? If they're not, you need to bag them with oxygen. So I said most seizures only last a couple minutes. You have a question?
During seizures, I don't know, I might have missed it, but don't you hold their head?
Why?
I just see everyone, but I've seen them, that's what they've always done.
Because they're all dumb. Y'all gonna be smarter than that.
So
It's
just
a-
let them just.
Yep.
let
You
'em
can't
go.
do anything. You know, holding their head, it's gonna, every
Just say they don't want
muscle.
their head to bang against things.
I put a pillow under it.
They
You
can
know.
hold their head.
I'd be afraid if I put my hands on it, they're banging, they're gonna break my fingers.
They'll break their neck.
You know.
Yeah,
I just,
hold
you know,
their
put a
head.
towel, put something under there. Holding their head's not gonna do any good. If they're violently pulling against that, while you're trying to hold their head, you run the risk of doing more damage. So just make sure they're safe. If you want to put something padding under their head, not a problem, but you don't want to hold them in any way. Now, if the seizures lasted more than a minute or two, you could use some blow-by oxygen on there, and there's nothing wrong with that because they're really not breathing much when they're seizing. They're basically holding their breath because they're not able to expand and contract the chest because every muscle is taut in there. So afterwards, you may give them some oxygen, depending on what you think you need to do. If they've injured themselves during the seizure, you may treat that. If they've bitten their tongue, you may have to suction. You have to put them on their side. Any other injuries? Say you had somebody that was standing up somewhere, and for instance, did I tell you about my neighbor that had a seizure? When we first moved to Spanish Fort, my brother and I were out taking a walk, and I saw this man. I didn't tell you all this? Yeah, the man that was with his dog, was taking his dog out for a walk, and he had an aura, I guess. His dog knew that he was going to seize and got him down the steps. But if he had started to seize on the top of those brick steps and then fell all the way down, now you've got somebody who's hypoglycemic who's had a seizure, and they have a head injury from falling. So you may have to treat evidence of traumatic injuries. I mentioned status epilepticus, 2 or more convulsive seizures lasting 5 to 10 minutes or more without regaining full consciousness. The key here is multiple seizures without an intervening period of consciousness. What's the matter? You thought you were going to have a seizure? You're going, if she didn't let me out of here soon, I am going to have a seizure. I'm waiting to see some hypoglycemic seizures in here. I think I might have one myself. That scares me. Status epilepticus is a critical emergency. If you've got a patient in status epilepticus, you need to be calling ALS backup. You need to be calling for an intercept somewhere. Okay, ready for the next kind of altered mental status? Stroke. Sorry we're going through this quick. Y'all are. Sure are.
What if we don't get home?
I think we have 3 chapters on Thursday. Yeah. First we're going to start at 5 o'clock. I don't think we have, how much we got left? Yeah, see, we're doing fine. We'll make it. Oh, crap.
30 and 20 minutes?
Oh, crap. What were we on, 66?
We were on the
60.
flight.
I think
We were on 90.
93.
We were not?
We're on 60.
60.
Oh, no. Oh,
Yeah.
heck.
Yeah.
60.
Let's just break, 'cause I'm
90.
losing my consciousness.
Did you have any before?
No, actually no, because I've not felt good this entire time.
Do y'all want to stop here and pick this up on Thursday? We can do that.
Ooh, Thursday we got 3 chapters.
I think so.
But they're probably not 96 slides.
Yeah, we should just finish this now.
But this means there's more to do on Thursday. That means
Yeah.
a shorter week.
This stuff is so important. I would really rather take the time with this. Let me, where's this thing?